To the PCPlus webinar today. For those that don't know me, my name is Loretta Dutel. I'm the Operations Manager for the Delivery System Reform Unit. And today we are planning to provide you just a brief overview of PrimaryCare Plus, just kind of sort of level setting, also talking a little bit about the next steps that's coming in the next weeks, months, and years. And our goal is also to have an opportunity to get feedback from you all, to hear about how the model is currently working for you. And then we will plan on wrapping up after that. And Cheryl, can you share your slides, please? Next slide. And we're just going to start with a little bit of housekeeping. If you have any questions or comments as we go through the presentation, please utilize the raising hand function in your in the Zoom meeting, which is down at the bottom in your tools. You can select the raise hand, and you can either toggle it on and off. The option, you can also have an option of using the Alt-Y. If you are a telephone user, you can press *9. And we also have an option to enter questions or comments in chat, and we'll be checking that periodically throughout the presentation, and we'll be pausing to address some of those. Next slide. All right, so I will hand it over to Olivia Alford. She is the Associate Director of the Delivery System Reform, and she'll be kicking things off today. Thank you.
Great, thanks, Loretta. So my name is Olivia. Again, happy to be here today with many of you that I know well and others I don't. We're really excited about this work to continue to invest in the PrimaryCare Plus model and how that model can help transform and support primary care practices in primary care going forward. We are doing this as part of MaineCare rate reform, which you may have heard of as a large scale. Hold on one second. I'm sorry, my dog is barking so loudly. One moment. I know you all can't hear it, but I can. Okay, so MaineCare rate reform has been really a hallmark effort from this administration to make sure that we have a process to set MaineCare rates, in the process that is data-driven, that includes giving opportunity for comments and engagement from partners, and that it goes systematically through all MaineCare services so that there's more equity in which rates have been revisited, which ones have been revised, and how we keep those rates up to date so we don't end up in a situation where MaineCare rates have fallen far below where we would want them to be. So it's a process that we follow for every similar project like this. And so we want to just take one step back today and say that we are in this process with you all for a rate determination, as we call it. We are in this step 2 here, where we are engaging around reviewing national and state data to inform what the next phase of PrimaryCare Plus could look like. We will have formal public presentations, formal public comment periods, and all those things to follow, but really we're just at the beginning of this process. There's other things that go along with the rate reform process and the rate reform statute that governs our work at MaineCare, which you can read about on the slide, but I won't go into today. Next slide. When it comes to PrimaryCare and PrimaryCare Plus, this is going to be a potentially multi-year effort for reforming or setting up the next stage of primary care reform. As you know, these larger scale projects take time. So we really are in maybe the first bucket here of background and research. We've been doing this, preparing for this next phase since we launched the first phase of PrimaryCare Plus in 2022, but we've been now officially launching into the next phase of data collection, data analysis with our contracted partner, Manat Health Strategies, who is not on the call today, but is the vendor supporting this work for MaineCare in the initial phase of PrimaryCare Plus redesign. So you'll be hearing from Manat in future webinars, and Loretta can talk about some of the future engagements later on in this call. But we'll be moving through several steps here, and we'll be eventually landing at a place, again, anticipated to be over a year out, where we'll actually be proposing what the revised rates themselves will be for Primary Care Plus. Initially, again, just focusing with Manat on how we're going to design this model, what would be the best, what are we seeking to achieve, what kind of structure are we looking to put into place for primary care going forward. So with that general overview, I'll hand it back to Loretta for a few minutes before I come back on.
Great, thank you. So I'll just be providing just a brief overview of the PCPlus program and an overview of some of the trending data that we've seen since PCPlus started. Next slide. So PCPlus started back in 2022. It's a consolidation of 3 of our other primary care related programs that we had prior to that time. They didn't work so well together, but with PCPlus, it streamlines some of the components of those programs and really changes the way that MaineCare pays for primary care services. PCPlus encourages practices to utilize care teams outside of their primary care practices, such as potentially community health workers, community care teams, and other care teams that support patients and healthcare outcomes. The model aims to improve healthcare quality while also reducing costs. And PCPlus practices receive a monthly payment that reflects the quality and type of care that they provide, as well as the patient populations that they serve. Next slide. As a reminder, there are 3 tiers of 3 tier levels in PCPlus, and these are some of the requirements of each of the different tiers. Each of the tiers, just overall, each of the tiers build on each other. So if you qualify for tier 2, you must meet qualifications for tier 1, and if you qualify for tier 3, you must meet all of these requirements. And just to note that the calculations that went into each of the tier levels did consider the requirements of each of the different tiers. So for example, you'll see in tier 2, there's a requirement for community health workers. That component, and of course, all the other components, requirements within that tier were considered within that PMPM payment when that tier was calculated. Next slide. So this slide provides an overview of the current payment methodology for PCPlus practices. And I just wanted to note that later in the discussion today, we will be looking forward to hearing from all of you about how all of this is working for you. And we have some questions that we'd like you to think about as we review this information with you. And we've listed some of the questions here. We probably won't be covering all of these questions, but we will be sharing a survey with you as well. We'll share that information at the end of this meeting, and it will give you an opportunity to provide some written feedback about how PCPlus model is going for you. And so just a brief overview of the current payment methodology. So PCPlus practices receive their normal fee-for-service payments. They also receive which is called a population-based payment. The population-based payment is based on the practice characteristics that we just went over, and also the patient population. It also includes an overall risk based on that patient population makeup. So for example, if you have, it looks at the children, adults, aged, blind, disabled, and that dual eligible population as well. So the combination of these factors is included in your population-based payment. So as a PCPlus provider, you receive the fee-for-service payment and the monthly population-based payment. Next slide. So these next few slides, we'll be reviewing the data of the PCPlus program starting from back in 2022. This slide provides a nice overview of where all the PCPlus practices fall in terms of their tiers. The majority of the PCPlus practices, as you can see, fall in tier 3. which did create a drop in Tier 2 practices with those transitioning to Tier 3. And Tier 1 has been fairly steady over this time. Next slide. So this is a current overview of how PCPlus practices currently look today in terms of the type of PCPlus practices enrolled. The majority of practices are family practices, with a smaller portion covering the categories such as pediatric and internal medicine. And then also we have 3 out of the 4 tribal health clinics in PCPlus. Next slide. This shows the trend of the members that are attributed to PCPlus practices over the years, with a noticeable dip coinciding with the eligibility changes following the end of the public health emergency. I will just pause here because Cheryl Malik is sort of the person that works on our attribution with PCPlus. So I'll pause here to see if she has anything else to add.
Yeah, as Loretta noted, there was a drop due to the removal of a lot of members due to the end of the public health emergency. And then there are also, as many are aware, we've started to see changes in practices, some transitions of practices, merges, closures. So that has an effect as well. And we have seen some challenges in billing practices that have affected attribution. So where this is a service location based model, we do stress that practices attribution is dependent on appropriate billing occurring at the service location of the service. So that certainly impacts attribution as well.
Great, thank you for that, Cheryl. And next slide. So PCPlus practices, as you can see, serve a broad range of patients. This is an overview of the population of the patients that PCPlus practices serve, with the majority being children, followed by adults, a lesser amount of dual eligible and age blind disabled. And these are also the categories that we reviewed in terms of your patient population and risk assessment. So I said a lot really quickly, so I'll pause to see if there are any questions or comments. All right, not seeing any, I will turn it back over to Olivia.
Great, thanks. So again, MaineCare Plus just launched, I guess, 3 years ago now, and it was really a huge step forward for primary care within MaineCare. We used to have several models that really were disjointed and served different providers, different member populations, had different incentives, and we were really glad to bring it all together under Primary Care Plus. Where we are now with Primary Care Plus, if you think about it in terms of an alternative payment model and where it falls in this healthcare payment learning and action network framework, which articulates the type of alternative payment models that a payer can offer, we're in this category 2C. So we have fee for service, yes, but we also have pay for performance, or I should say we're currently really in 2A. We have these per member per month payments that go on top of fee for service, moving to performance based. And that's great. That's a great place to be. We've kind of solidified the work around Primary Care Plus and set up this tier structure. We've set up information sharing around quality measures, and we're getting to the point where we're scoring those quality measures. So all of that has moved us from purely in the orange to more in the red category 2C. With Primary Care Plus Phase 2, we're really hoping to take another big step forward and move into probably category 4, population-based payment for Primary Care Plus. The further you get down the HCP land framework, the more flexibility there is in the payment model, and there's ties to accountability for the outcomes that the providers the members achieve under those more flexible payment arrangements. If you go to the next slide, I want to talk about how, while I'm thinking and we're talking about this category 4, we really are yet to determine what the payment model looks like for Primary Care Plus, and that's why the rate determination, that arrow of all the different stages, is going to take us some time to get through. Right now, we're doing background research, understanding our claims data with our vendor. We're talking to you all, as we have been for several years, and we're figuring out what type of payment model is going to look best for MaineCare to move forward with in primary care. A common primary care model progression that takes place for other payers is kind of where we are now, is that they start to add supplemental per member per month payments on top of fee for service, and then they might move to a population-based payment that partially replaces fee for service, and then maybe even in the future beyond that, they turn everything into a population-based payment, full capitation, and there's no more fee for service. So that's sometimes that's how primary care payment reform looks. I'm not saying that's where MaineCare will land, but if you're trying to just visualize in concept where we are going in concept, it's sort of along this framework, and we're just trying to get from the initial phase to maybe the next step with this reform effort. Next slide. With our partner Manat, we have articulated some aims for Primary Care Plus Phase 2 and principles. So you can read them here on the slide, but we really want to create a model that improves health and health outcomes, improves access to primary care, and really supports practices in delivering whole person care. And that we believe that the way to do that is through an alternative payment model that, again, is further along in that payment framework. We would love there to be multi-payer alignment, because we know that supports practices in really transforming the way that care is delivered, and we'll continue to strive towards that, though it's not fully in our, it's not really in our control, but we'll continue to strive for it and support it when we can. And we want to make sure that we continue to drive home some of the principles we've been working on in this MaineCare delivery system reform team for a long time, about fostering partnerships and coordination across different parties in the healthcare and community delivery systems, so that there's better leveraging of each other's strengths, resources, and information sharing. We will continue to engage with you all and other interested parties throughout the entire process. We've been doing that pretty steadily since we started designing Primary Care Plus Phase 2, and we hope that you see us as very accessible. So you can reach out outside of these meetings as well, and you'll receive future invites. And then we are really interested in creating a structure that at least streamlines administrative burden for both you all as providers or members as well, and then also for the MaineCare side. So that doesn't mean that we'll be able to remove administrative burden, but it does mean that we can focus on creating value out of what administrative burden does exist. And that's a continuous effort, and something that we were holding as a close principle here. Next slide. So where we are, again, I might save this for you, Laura, to touch on later, is we're evaluating how we are currently meeting these objectives and aims, and what we can do to change those in the next phase of Primary Care Plus. You'll be hearing about some opportunities to hear more about this current state analysis. But again, this meeting is actually part of that, because we're going to hear from you. Next slide. All right. The last slide here is just to say that as a general level setting, again, this primary care redesign, Primary Care Plus Phase 2, we're including all types of primary care practices. Again, we want to keep that consistency where it's both independent, hospital-based, FQHCs, rural health clinics, tribal health clinics, all operating within at least the umbrella of a same primary care program. We are looking to change the actual payment methodology design, as well as things like refining attribution if we need to fit within that new payment design, and refining and building on the care delivery requirements, those tier requirements that Loretta looked at. We're going to be revisiting those as well, And again, the goal is that all of these things feed into the same incentives, that we are creating this flexible payment model that meets members' needs and improves health outcomes and gives providers the flexibility and accountability that they can use to provide that care. Really important last thing is that I mentioned this before, you'll be hearing from us, you'll be hearing from Annette over the next several months. That's all design work. There'll be a separate kind of initiation of actual calculations of rate. You all may recall, if you've been with us for several years, that when we launched Primary Care Plus Phase 2, we shared our best estimates of specific methodologies and fiscal impacts to providers about the shift from where we were before to Primary Care Plus. All of that really specific financial analysis work, rate setting, will be at a later stage because we want to focus on the design for the next several months. Things that will go into the design include really looking deeply at community health worker reimbursement and also looking at social risk adjustment, or as it's called here, HRSN, health-related social needs risk adjustment. And then again, all the attribution, care delivery, and payment model elements that I just spoke to. All right, I'll hand it back to you, Loretta, to get some engagement.
Great. I'll actually hand it over to Cheryl to talk a little bit about the feedback questions that we have.
Yeah, sorry, Jill had a question, so I'll just jump in. I forgot to pause for questions. Yeah, so quality data. So we have all but one quality measure that's being shared quarterly, right? Quarterly with Primary Care Plus practices via their reports on the quality measures and how they're performing. There's one remaining quality measure that we're still aiming to launch, total cost index, which would be the last one that's needed in order to calculate a performance-based adjustment to your PM rates. So we have not started actually adjusting payments for quality performance, but providers have been receiving data for a long time to start to get to monitor their performance and understand those measures. And we're still planning to do that, just waiting to make sure we, as well as you, are comfortable with the data that we're sharing and that the measures are being calculated correctly, and then we'll go about actually augmenting payment based on those. Yeah, this is good. So this, and Melissa's saying there are no goals or gap lists. This patient's not meeting. Oh, okay. So yeah, so maybe some technical assistance on how to use what your data you're receiving for the quality measures, or changing the reports so that you know who's meeting the numerator and then who's not meeting the numerator. Yeah, that's a great feedback. I'm starting to get into Cheryl's territory. I'll let you give more feedback to Cheryl as she goes through these questions. Thank you.
Yeah, and I'll add to that. Whereas we've been providing all the data via email, we're trying to be overly cautious in sending out PHI because that, of course, increases risk. But you can certainly reach out to us at the email we sent, and we can maybe coordinate something to provide some more detailed information member level to you. As far as the goals, we're currently doing measurements looking at comparisons to each other. Again, as Olivia said, as we move towards quality-based adjustments, we're going to be looking at that in multiple levels, right? We're going to do comparisons to each other, comparisons during a base year as well. So there'll be, as we get closer to that, there'll be some technical assistance so we can go through that information more closely with you. So this screen looks familiar. Loretta had talked about this earlier. As she noted, we'll be sending out the survey for multiple questions for you to give us some feedback. So what we're going to do is just do a couple quick polls. We're only going to actually address 2 of these questions during this call today. And then if you could please, when you get the survey link, please go in and give us more details. as far as what you think has gone well. That's going to be our first one. So I guess we can move forward to that. These are going to be the questions that we're going to have on the poll. That's going to be initiated here in just a moment. Again, there's the other, which you won't be able to explain in this poll on the webinar. But if you could please, once we send you the link to the survey, if you could please provide us with more detail as far as your thoughts on this. So this is what aspects of the PCPlus model have gone well for your practice. Reimbursement stream for non-billable high-value services, clear practice requirements, expectations in PCPlus policy, better patient care coordination, focused performance measures, clear identification and rationale for patient attribution, and of course, other, which you could certainly choose other for now. And then we look forward to getting further information from you if that is something you're interested in reporting out to us.
My apologies, Cheryl. I think I just opened the second question.
Oh, so let me go.
We'll start with
So
that one
is,
first.
oh, that's concerns. Okay. What are your practice's primary concerns or priorities regarding MaineCare's next phase of the PCPlus APM? Looks like we've got 32% participation so far. So I can just read these out. Sustainability of funding, reimbursement, administrative burden, maintaining or improving patient care quality, meeting performance metrics, identification and rationale for patient attribution, timely and clear updates about the next phase, moving away from fee-for-service reimbursement, multi-payer alignment, and again, the other, we would really appreciate if you fill that out when we send the survey out to everyone. Again, this is practice's primary concerns or priorities regarding the next phase. We're just over 50%. So we'll probably give it just a couple more seconds. Looks like we're probably not going to get much above that, Loretta. Oh, one more. Cool. Looks like we've got, currently we've got 76% for sustainability of funding and reimbursement, 59% administrative burden. Is anyone interested in giving us your thoughts on any of these?
Yeah, Sharon's got her hand up. Go ahead, Sharon.
Go ahead, Sharon.
Oh, she took it down. We lost her.
Okay. Anyone who want to give feedback?
This is Will. I can't really raise my hand for whatever reason, but I can share a couple thoughts.
Great.
Sustainability of funding and reimbursement is I think it's the most important piece of this. Just getting payment for those other care team members just doesn't fit in fee for service. And we know that's not how primary care functions. It's just going to be a bigger team to function well. And then I had multi-payer alignment too. Doing these things piecemeal with, I don't know, 10 or 11 different payers gets complicated. If we could get even 4 or 5 payers aligned, that really could start to change behavior in a bigger way.
We don't disagree with you there. That's for sure. Thank you. Cindy also noted, Oh, sorry, did I cut someone off?
I just unmuted. I'm sorry. This is Sharon. I'm
Hey.
trying to drive and I couldn't find the unmute button on my phone.
Gotcha.
I just had a quick question around changes that are going on in other areas that affect PCPlus, and just wondering if MaineCare has given any thought to it. So all of the participants in Health InfoNet received letters letting them know that the rates for the HIN connection were going up 20% effective October 1st. And so for some providers, that's a significant increase in cost. And because it's a requirement really of PCPlus, if you want to get above tier 1, it puts providers in the interesting position of deciding whether to maintain their connection and pay the increased money so they can get their PCPlus reimbursement, or to drop it and reduce their PCPlus reimbursement. So I just wonder if MaineCare even knew about that, or if they've been talking about it at all.
Yeah, I can take that one. Thanks, Sharon. We do know about that. And we are working on a lot of different potential paths forward regarding Health InfoNet. So you may not, in summary, there actually was a budget initiative last session that would have leveraged already existing hospital Health InfoNet participation fees to bring down federal dollars that would help fund the Health InfoNet, which was not approved by the legislature, even though it was not going to cost anyone any additional funds. But there was other considerations, and it was not approved. So that led to now us needing to look at other ways that potentially that we can leverage federal dollars to support the Health InfoNet requirements that we have embedded into several delivery system reform units models, because we do think it's valuable, and we hear the value from participants about using Health InfoNet in these models for care coordination, discharge planning, transition planning in general, and then some quality related work. So we are actively exploring that, and yes, we see the connection, and we're hoping that we can find different paths forward. But if you have specific concerns, Sharon, we can talk more about those in the short term. And I think those fees increases are for October, perhaps.
Yes. Yeah.
Yeah. So we are aware. Yeah, working on it.
Cindy also noted in the chat that she will elaborate on written survey as well, but she wanted to ensure that PCPlus does not follow in the tracks of Primary Care First, where the payment methodology was confusing and as a result compromised improvement.
Yeah, and I would love to, I'm sure you said you'll follow up with more detail, but when the visual that I was talking through was sort of what you would call a partial capitation model progression, and but we know that flat visit rates is what Primary Care First used. We have heard mixed reviews on the flat visit rates, and it wasn't something I spoke to today, but would love to hear more detail in your follow-up about what made it confusing and didn't support the quality improvement, because that we just want to make sure that we consider all options.
Yeah, I appreciate that, and I will. And I think I'm thinking more on the practice, the PBAs, I can't remember what they stand for now, the performance-based adjustments. And it's not that they compromised improvement. I should have said they didn't drive improvement because they were so confusing. But happy to talk more about that or write more about that.
Great.
I'd be glad to chime in for a second here. My name is Joe Anderson. I'm a pediatrician in small town coastal Belfast, Maine, and appreciate all your hard work. And our experience, we had the PCPIP payments, which were good, but now we've taken a significant pay hit with the PCPlus, and we tried to bump up to tier 2, but we found the administrative burden in this small. I'm a solo practitioner here in Belfast. We're the only pediatrics office in Belfast. We found the administrative burden to try to complete either the patient-centered medical home part or the remaining 40 requirements just not well tuned to a pediatric practice instead of just a family practice, and some of which were just completely, it was a crippling administrative burden, as well as some of which were not even oriented towards pediatrics. So, I see that I saw with interest here almost 50% of the PCPlus clients are children, but there's very few pediatric practices or especially solo independent pediatric practices. So, I mean, I have a very small slice of your pie here, but I just feel like my practice is just getting left out in the cold here. It makes it increasingly difficult to do business as our expenses and our staffing concerns continue to be problematic. The hospital recently raised our rent by about 40%, and everything's getting more expensive in the state of declining reimbursement.
Thanks for sharing that. And I think it would be great to follow up. There are, as you said, especially independent pediatric practices, not as many. The having some like really focused conversation with small practices about which requirements are most problematic and what could be done to reach a more appropriate goal for your population, especially pediatric populations. Like that would be a great conversation to have and really focus just in on those smaller independent pediatric practices would be really probably a good special conversation to have.
And comment of support about the struggle of even systems to do some of these programs. So thank you. Any other comments? Loretta, do we want to go back to the previous question and do a poll for that? That has been posted. Please feel free to respond to what aspects of the PCPlus model have gone well for your practice. And then we'll summarize again and take feedback. Looks like things are slowing, hoping we can get a little bit closer to 50%. All right, guess we'll probably, anyone wants any last minute feedback? All right, it's looking like for 70% clear practice requirements, expectations in PCPlus policy, and 55% reimbursement stream for non-billable high-value services. It's great. Anyone want to speak to any of these things that have gone well?
I can't find my hand. So this is Cindy. Let me just jump in. Again, comparing to primary care first, I think we appreciate the stable revenue that comes in quarter over quarter. It is hard when things change drastically quarter over quarter. So having that kind of stability and predictability, not that we shouldn't have adjustments if things change, but having some kind of predictability for our investments is a strength.
Thank you, Cindy.
And I'll just add to Cindy, I mean, it's timely too. This isn't you do something for a year and then 10 months later you get something out of it. It's you can budget for this, which you can't do for a lot of things, and that's super important today.
Thank you. All right. So that takes care of these two questions. As we said, let's see, actually, we can put this in the chat for the full survey. If you please could take a few moments, and if there's others that you feel in your staff that might have some feedback, please feel free to submit this to us for the additional information of free text that you have the ability to enter in the survey. We appreciate your feedback. Again, and we also have our next webinar on August 11th. Those of you that are getting our e-messages, you would have received a recent communication that noted this rescheduled meeting for today, as well as the meeting with Manat on August 11th. Also, if you are not yet receiving our e-messages, we encourage you to sign up, which I believe there was some information at the bottom of the forwarding of the e-message, or those of you that got the direct e-message. We also sent e-messages out directly to emails for you all to get notification of this meeting, and also putting additional information for e-messages in the chat as well, so that you can go in and complete e-messages. It's delivered to the MaineCare provider facing messages, primary care and care coordination area of the e-messaging. This is how we communicate with PCPlus practices on a regular basis. We do, for some of you that have direct emails with us, we also send to that, but it's really important to get on the e-messaging listing. Now, if there are any final comments, Loretta or Olivia?
Yeah, I'll just say, so the next meeting gets into a more quantitative look at the meeting next Monday about MaineCare spending on primary care and different slices of that. It's a really broad look at primary care, and that'll be facilitated by our vendor, Manat. And then we'll go forward from there into more detailed conversations about changes to attribution, care delivery requirements, and payment models. So this is going to be, again, multi-month. Look out for these opportunities, and please do reach out with other questions in the meantime, because it'll be really great to build this together over the next several months. And we can send out the slides and post the slides on the rate reform website for MaineCare. All right. Thank you all. Have a great rest of your day.
Thank you, everyone.
Bye.